After having an overdose of, I think, central serous, we move on to another common disease, which I thought we know everything. You see, I still believe that, I hope this is visible, Jay?
Yeah,
Yeah.
we are good.
So I still believe that laser is still the mainstay in PDR. And we all understand when to do all this HRC. Without HRC, I do scatter laser, and even sometimes in very severe NPDRs also, especially if it is non-eyed patient. So PRP, pan-retinal photocoagulation or full scatter, long decades we have been doing this. But this is when our thought process got changed primarily because of pharma pressure of the companies that once they compared in this protocol S with the ranibizumab and said that it is non-inferior to uh, PRP. So this is one of my patient who had florid kind of PDR with a lot of non-perfusion here. So this since this was very close to the posterior pole arcade, and so I did inject ranibizumab, and after that followed it up with scatter laser, and it did pretty well. I'm not sure whether repeated injections would have done the same or not. This was another patient of mine who had, you see, the number of fronts at the posterior pole with a lot of non-perfusion. Here again, I gave the same biosimilar injection, which I very commonly do, front at the posterior pole, and again followed up with laser. This patient again had stabilization. So this is another young patient which I wanted to share and in fact ask. This patient I had seen long time back, and from 2018 till today, this young IDDM girl uh, had good vision in the beginning. Then again for 2 years or so she lost to follow up. Then she came with florid PDR in the beginning of last year, and vision was still maintained. If you see September 2026 by 9 vision. In between, I had done a lot of laser for this lady, and suddenly, after 2 months of this, she presented with a combined RD and then took her up for surgery. This was the story of the right eye for 2, 3 years, and this similar fate was there in the left eye. If you see florid retinopathy developing very fast, and despite laser, this patient had again a combined RD and had to do a surgery here. In contrast, this was a patient who also was IDDM, and had the difference between that young girl and this gentleman was that intervention was faster, and both these eyes, see left eye, right eye, recovered good kind of vision. The retinopathy was not so florid in this. So I'll just skip this video. So we all understand vitreous surgery in DR. We'll not go into this, but the indications which are becoming more commoner are combined RDs and macular TRD. The vitreous hemorrhage, non-resolving, we rarely nowadays get. So these are the post-ops, couple of patients. So outcomes have definitely improved with better quality machines and smaller gauge vitrectomies, preoperative anti-VEGFs, and even bimanual surgery. I still do once the fronts are sticky and stuck onto the posterior pole arcades. So what I wanted to bring out in PDR is that judicious use of all these modalities for the maximum benefit. Laser, I still believe that a good scatter laser, because have so many eyes where decades back laser has been done and maintaining very nice vision. Anti-VEGF created confusion by some people doing it as the first line of treatment. I still believe that it's an adjunctive role only. Although studies, long-term studies also are available, shows non-inferiority, but issue is of repeated injections, cost, and multiple visits, etc. I do anti-VEGFs only if there are recurrent oozes despite laser with good vision, or there are posterior pole large fronts, as I showed in two of my patients with good vision. Because if you do dense laser there, then there may be fibrosis later on. Other thing is that these two patients taught me that early vitrectomy in such patients adds to the long, and don't wait for very long time, because you could compromise the ultimately visual results. Patient may not gain much. Prognosis has improved thanks to all these multi uh, attacks which are available. Thank you for listening this.
Thank you
I
so
just
much.
wanted to ask about the panel about how do they approach? Do they still do anti-VEGFs repeated, or anti-VEGFs first and then lasers, or lasers alone?
Dr.
Why don't
Verma,
you
I just
start?
gave a talk in the other session about this too, so I can answer the question. I think the vast majority of people, at least in the United States, have not adopted anti-VEGF as the primary therapy for proliferative disease. Rather, we take a blended approach. 25% of individuals say that they have started using anti-VEGF as primary therapy for PDR. The problem obviously is compliance and return to the patient and not doing that. But I would say that everyone, I think most of us have taken, as you did in your cases, not a strict approach to using laser alone, but using an anti-VEGF, then waiting because we schedule these patients for laser and then doing the laser. And then if they have recurrences and bleeds and you don't have time to repeat the PRP, you can stabilize with an anti-VEGF and continue. I think the big finding from Protocol S, at least for me, was that when treating with an anti-VEGF, you didn't end up with massive tractional detachments or crunch syndrome, as they used to call it. I think that was really, really reassuring. Again, I would say that the patients in Protocol S were not high-risk PDR, though. So those were very different stages of PDR. So in the high-risk PDR patient, we might see a different outcome. But I think we take more of a blended approach for this whole matter.
Yeah, as part of the DRCR net, I agree with Rishi that these were not severe cases. There was definitely a little bit of a bias in enrollment into the clinical trial. Definitely not macular threatening traction detachment patients, for instance. And even though there is no clinical trial data, for whatever reason, US people are doing the blended approach. There is no clinical trial data to show that the combination treatment is better, but most people are doing it because of the lack of follow-up. I've been burnt as well. You know, I start injecting with anti-VEGF, but then they don't show up. And then next thing I know, there's huge traction retinal detachment and other things. So there may be a benefit to combination doing with anti-VEGF first so that you don't get the edema, macular edema, and then adding PRP for more stability or durability.
Jay, I just want to add one point.
Yes,
Lalit sir.
please.
Sir, usually if we look into this protocol S and all these things, we use anti-VEGFs only when there's no fibrovascular polyps. But when I see your case, the girl who already had a peripapillary traction, the peripapillary fibrosis was already there. So I don't think in those cases anti-VEGF really works well. And the patient was 6'9" in that case.
Yeah, 6'9" years.
Right.
So that was hesitancy of my intervention because she was working in a Google company, and
anti-VEGF will definitely worsen in those patients because even if we laser them or don't laser them, they usually tend to progress because of the poor control of the diabetes.
the anti-VEGF was not given to her. It was given before she came to me, was given to her before that.
Yeah.
So I agree, because once the fibrosis sets in, anti-VEGF may sometimes worsen the traction.
And I would love to ask the panelists, in these peripapillary tractions, how many of these cases usually they tend in for going in for the major CRDs as what Dr. Lalit Verma showed? Because most of them do well if the sugars are under control, but the peripapillary traction once develops and they develop the CRD, whatever surgery, beautiful, fantastic surgery we do, but the visual improvement will not be as much as the patient had without peripapillary traction. So I feel that peripapillary traction itself is some kind of loss to the patient.
Yeah.
Yes, many of them then end up with macular holes, and then
So,
no matter what you do.
what I've seen is these kind of peripapillary tractions happen in two settings. When there is associated nephropathy, there seems to be a higher incidence of this kind of peripapillary traction, the retina being pulled over the disc even. Also, what you're talking about, the poor prognosis, also because very often this is associated with macular ischemia. Macular ischemia. That is why the traction, when it happens, the ischemic retina is not able to bear that and holes happen. So that this is what these are 2 points that are just like.
And Srinivas, I think if you have a vitreopapillary retraction, that itself becomes an early indication for surgery.
Yeah.
You know,
But-
you don't have to wait for giving
I
an
agree,
you
but
can-
if the patient is six parts and you have a vitreopapillary traction and very florid NVEs in the posterior, very thick other end membrane, then I'm sure that sometimes we might burn our fingers, burn our
No,
hands.
so if in these cases, what we did was you plot out you do a field charting for them, and you find there's a large field defect with the patient having a 6.6 or 6.9 vision. And
So
in those cases, if you go ahead and operate, you actually can convince the patient that you need an early intervention.
So my reason of presenting this young girl was she was working in this Google company and doing pretty well, and her vision, despite this florid, was 6.9. So we all know that diabetic vitrectomies may not be an easy job once you go inside and you see peel off all this or segment or delaminate all the membranes. So and she also was very hesitant to be touched in this particular